All right. Thanks for showing up for this compulsory department meeting. We're going to be talking about severe sepsis and sepsis shock here, focusing on the emergency department. The reason we're talking about this is one of the hospital's annual quality improvement type projects. The reason this was inspired by a high, I'm going to be blunt, a high sepsis mortality index for the hospital. This is some kind of way that the authorities try to see if you're having more deaths than you ought to in septic patients, and sure enough, it's been high. So, I mean, we got to double check that we are meeting the standard of care. You know, let's just do a double check and see what we get. So the thing about sepsis is, I mean, there's a lot of diseases we get worked up about in the emergency department. These golden hour diseases, like MI, you got to get into the cath lab yesterday or administer the thrombolytics in such a time. Stroke is a 3-hour time window. And we're saying this is like those. It's a golden hour disease with a time window, okay? And the mortality for the severe sepsis and septic shock is, I mean, it's in the neighborhood of the STEMI. It's like, maybe a third or something like that. And so that's why we should be feverish about the severe sepsis as we are about those other diseases that have a big drug sponsoring the hysteria, okay? So so this is severe sepsis, okay? And now a lot has been tried to deal with severe sepsis over the years. So for like a long time, they were trying, basically, besides the antibiotics, what else can you do? Trying to just optimize oxygen delivery and hemodynamics, blood pressure, etc. for the patient. And they were doing, having placebo versus all this aggressive care in the ICU, and it wasn't working. Nothing was making a difference until this study finally came out. It was a famous emergency department study, the Maney Rivers early goal-directed therapy trial, where they did all the same ICU stuff that wasn't working for severely septic patients, and they did it in the emergency department instead. They did it early. They accomplished all the goals within 6 hours instead of that night or the next day in the ICU. They did it early, and finally they see this 15% mortality reduction, which again is a lot like your supposed benefit of thrombolytics and stroke, like your number needed to treat in the 6 range. Treating 6 of these patients early instead of late could save one life. That's the idea. And now I'm going to be saying, I'm not saying you guys need to keep the patient in the emergency department for 6 hours. That's just how some hospitals have to do things. But the point is that wherever the patient is, that it gets done early. And so, since this trial came out, it was like in the early 2000s, I think, they pretty much took the study protocol. They made these surviving sepsis guidelines that have been updated a couple times since then, and this has kind of become the standard of care that everybody talks about, surviving sepsis. You can Google surviving sepsis or go to the .org.com website. It's all sponsored by the Society of Critical Care Medicine. This is a guideline just like you have for stroke and MI from the AHA, et cetera, et cetera. And one hospital after another. Now, here's the deal. I mean, you can try to pick apart the Maney Rivers trial and say, boy, do we need to do all this stuff, or which part was important, which part wasn't? I mean, the bottom line is, since that came out and since these guidelines have come out, one hospital system after another has done their own observational trials. After we started trying harder to do this stuff, did our mortality rate go down? And over again, that is what has happened. And so that is why we say, in general, we think that all this stuff is a good thing to try for. Okay? So, to address what we did, instead of saying listen to the guidelines, we had a medical staff meeting where we invited their trusted consultant, Kamal Shaker, MD, the intensivist from Metis Medical Center. He's on the faculty at OHSU. We said, please come down and just tell them what you would do after the patient's been here for 3 days and we cannot help them. You come here, tell us what you would have done in the first, 6 to 12 hours, and we'll do that. So we came by, and here's the medical staff meeting, and everybody's there. There's Rex Parsons and the surgeons and all your, a lot of your ED doctors. It was very well attended, And he basically just described doing it by the book for the most part, just pretty much following the guidelines. Nothing too original or out of the box here. So that's where we are. So this is not something I'm saying that the nurses are in charge of, or it's up to you guys to tell the doctor what to do. They should be familiar with this stuff. For the nurse, it is very important because we're talking about all this stuff getting done in 6 hours, and it can't get done in 6 hours unless the patient is rapidly triaged and recognized as having the severe sepsis. So that's why in triage you're looking for these like SIRS vital signs. That stands for SIRS. Yeah, it's the systemic inflammatory response syndrome. So these are just like vital signs. You consider them like so if chest pain is like the thing you're looking for For MI, that you might need to hurry up and do a bunch of things real quick, the SIRS is the chest pain of infectious disease. And so, I mean, it's pretty much the type of stuff you'd associate with severe infection, okay? They're got a high temperature, or they're very cold. Andy says, like, if their pulse is higher than their systolic blood pressure, this is you might have severe sepsis, okay? Hyperventilating, altered level of consciousness. If you happen to have, the idea is you could identify this stuff before you have any labs, but if you happen to have a high or very low white count, or their glucose is completely deranged out of what ought to be normal for them, again, these are more SIRS vital signs. So basically, if you suspect infection, and if you've got 2 or more of these SIRS vital signs, you should say, well, I guess I'm going to kind of think about enrolling them in my nurse protocol for what ought to be done, right away. That's simultaneous with inviting the doctor to please have a look at this patient, okay? So what is basically, here's what you do. Just like you got a package of stuff, you do for the MI or whatever, you start an IV, okay? With your IV start, get a first set of blood cultures right there, okay? Because that's going to be what's holding up your antibiotics a little bit later, is the blood culture. So get that. Fill some tubes, and you can put in the order for the basic metabolic panel and a CBC, and the physician can change them or delete them or add it to them or whatever as they wish. And then also, you're going to have the phlebotomist come down, and when they're getting the second set of blood cultures, you want them to get a lactate at the same time, okay? Because this is like your troponin of infectious disease, okay? This is like the #1 lab is going to be the easiest way to tell if your patient's having severe organ dysfunction as a result of their sepsis. I mean, sepsis is like a really broad term, right? I mean, all it means is the patient has an infection and they're showing some systemic sign. They look bad. But severe sepsis and septic shock are what we're actually talking about, or what we're very interested in. So the lactates are going to be the thing that says, this is the severely septic patient, okay? And you're also going to grab some fluid, because that's going to be an important thing up front early to get the fluid started. So here is what you're looking at to say it's on. Now it's a severe sepsis patient. I've got a golden hour, and we've got some goals to attend to. So it's the lactate over 4. Okay, that's the cutoff. I think we made it so it's like red on the computer when it's over 2, but over 4 is like the really, bad one with like the super high mortality rate, okay? Or fluid-resistant shock. After you give them a great, they can come in with bad blood pressure, you give them all the fluid you're supposed to, and if the blood pressure has not recovered after that, that would also mean severe sepsis, okay? There's all these other, well, you probably can't read the little letters in red. There's all these other little markers of organ dysfunction that they also suggest looking for, but the lactate and the shock are the big ones. The kidneys are bad with the creatinine, the liver function tests, the platelets are low, et cetera, but I mean, getting the lactate is supposed to be your clue, okay? All right, so if it's on, okay, our first golden hour is the 3-hour window, and here's your goals for the 3-hour window. Complete getting your blood cultures, complete getting your lactate and getting that returned. Hopefully you've done that a lot earlier than 3 hours, because if the lactate is so elevated, you'll wish you completed this big fluid bolus in 3 hours, the 30 milliliters per kilogram. So they suggest it's a bit more fluid than they used to recommend a couple of years ago. Basically, I mean, you're not looking for 1,879 milliliters here, you're just rounding off. Okay, so what it means is like you're more likely to be given 2 to 3 liters than 1 liter in the emergency department, and of course the antibiotics, okay? The consultant, Dr. Shacker said there's evidence he feels like even the earlier you give the antibiotics, the better. So the goal is supposed to be 3 hours, but if you get them in the first hour, that's even better for the patient. The patient will have even better survival, and they got to be the right antibiotics, right? And you're not going to really know what they're infected with, so that's why we say it should be broad-spectrum antibiotics. So hopefully, if the doctor can figure out the source, you can target it to that and kind of have something a little bit narrow, but otherwise, I mean, you're going for your Zosyn and your meropenem, okay? And those are broad-spectrum antibiotics that kill just about everything. And we just added meropenem to your cart, so you don't have to call a nurse supervisor for that. And we put the Zosyns in the same drawer so you can find them. Okay, so these antibiotics should be easier to find. These are big guns to pull the trigger on, but we're talking about like a super sick patient here. Things like vancomycin, it's not a broad-spectrum antibiotic. It's only good against like 1 bacteria, okay? And it's a weak antibiotic. But, you might be administering several, okay, to cover all the suspected bugs there could be. What I want to say, too, also, we usually give our antibiotics over a half hour. For the Zosyn and the meropenem, you can push them a bit faster than this if you're trying to get things done. And also remember to give your quick antibiotic first, and hang the vancomycin second, because that takes like an hour to get in, right? Yeah, Rich?
Are they compatible?
I'd have to look that up. Probably not. You should have 2 IVs, though, right?
Well, until we get that second IV, we can get them both started in the same IV.
Yeah.
Theoretically.
We'll have to check on that. I can't remember off the top of my head. Probably not. Probably not, okay? That's just how it is. But you can get the beta-lactam type in real quick. You don't have to be a half hour, you over 10 minutes or something like that. Okay? All right, and remember the fluid bolus, 30 milliliters per kilogram. So your old school 70 kilogram adult, that's 2 liters, and for your modern day 100 kilogram adult, that's 3 liters. Okay, what if the patient weighs 175 kilograms? Are we going to give them 6 liters? I don't even know how to answer that. Where do you stop? I don't know. It sounds like a bad prognosis to me. Okay, so, and what's the point? I mean, you guys know in the emergency department better than they do upstairs that the fluid is a drug. It's not the water to help the patient's thirst. It's a drug to help their cardiac output and their oxygen delivery, right? So you're trying to go up this curve and stretch the myocardium so it pumps harder and give enough fluid to maximize that. So that's why they say a good 30 milliliters per kilogram is a good amount to start with, although sometimes we get very scared for the patient with heart failure because their curve doesn't, it's not so healthy like this. It's flat. And so we get a little trepidation about giving too much fluid, right? The consultant suggested this easy step as a non-invasive way to tell if it's going to be possibly beneficial to give this patient more fluid when you're on the fence. He calls it passive leg raise, okay? So here's what he does. He sets the patient up in the recumbent position, okay, semi-recumbent position. And then he flips them back and puts their legs up in the air. And what you're doing is giving them a virtual fluid bolus, right? You're just draining the fluid from their legs back up into their chest, okay? So you give them this virtual fluid bolus, and you see if it works. Is there a sign of increased cardiac output? So if you're really fancy and you know how to measure the stroke volume with the echo probe, you can do that. Otherwise, what you can do is just measure the change in pulse pressure, okay? The difference between the systolic and the diastolic. If that goes up by at least 10%, the patient will probably respond to a real fluid bolus, okay? About 8 out of 10 patients that respond to the passive leg raise will also respond appropriately to the fluid you give, 500 cc's of real fluid. Does that make sense? Like if the virtual fluid bolus works out, you can go and probably safely give them a real one. 500 cc's, okay? But to really get an accurate pulse pressure, you'd rather have the art line in than your non-invasive blood pressure cuff. Of course, the central line is kind of like the older standard of care for caring for the septic patient. And this can be a real bummer of an expectation for the emergency department to put a central line in all these patients. Now, some of the physicians, they really like to practice doing the central lines. They're very gung-ho about it. Other times they are not. So we would say, anesthesia is eager for your consultation, I mean, they're eager for your consultation to cardiovert the patient, but they're also eager for your consultation in the case of severe sepsis. And they want to come in and help you put in these lines, okay? So think of them. Think of them.
Yes, to be contrary, but, it seems like we're moving away from central lines in the septic patient.
Now we're going to talk about that,
the foreign body and the patient who's got bacteria swimming around. And can't you get that fluid volume via peripheral IVs, etc.?
Yes. I think that you almost always can, so I'm going to talk about that later.
Oh, but I got to go.
Okay, so, see you, Andy. Okay, so anyway, like the classic idea, what the guideline still says is, here's your second golden hour section, okay, within 6 hours, okay, to get the central line in and to, you get the pressure transducer, which you don't have in your department, but Dr. Epthal would like you to get it. It's pretty simple. He'd like you guys to learn how to set it up so he can keep his eyes on the patient a little bit more. But so you measure the CVP. Okay, this is a measure of how much fluid is coming in to the right side of the heart, and you want that to be over 8. Or if they're on the ventilator, they got positive pressure ventilations, increase in their intrathoracic pressure. Well, you need to have a higher CVP in that case, so 12 if they're on the vent. Okay, and if it's not that, keep giving fluid. That's the idea. Okay. Next, look at their map. And if the map is not good, if it's after you give them the fluid, if the map still is bad, you got to start them on vasopressors for that, okay, within 6 hours. And within 6 hours, you're trying to get the map above 65. And norepinephrine or Levophed is the better one compared to dopamine, which causes too many arrhythmias in patients with septic shock. It's not like dopamine is like killing countless patients, so the Levophed is a bit better. The dopamine comes pre-mixed, so if you have to hang that for a little bit, some people feel more comfortable with dopamine in a peripheral IV if you're stuck with that for a while, and maybe that's okay. So I'm not going to say you can never use dopamine, but Levoped's better. And then finally, after you've done that, what you want to do is get this central venous oxygen saturation. Have you guys ever heard of that, or do you know how to get a central venous oxygen saturation? It doesn't require any fancy equipment. Okay, all you got to do is pull a blood gas off the central line, off of the port that comes out closest to the atrium, and that's a venous blood gas. You run it through the machine, and the idea is that you're trying to deliver good oxygen. Okay, the blood is going around the circulation. It's coming back into the station on the right side of the heart, and if the oxygen saturation now is less than 70%, what you would say is the body is using up too much. It's hungry for more. Does that make sense? So you want it to be above 70% on that venous blood gas out the central line. And if it's not, you need to improve your oxygen delivery. If the patient is very anemic, you can give blood to increase their carrying capacity. If they're not anemic, the drug is dobutamine to increase their inotropy and contractility. I'm going to make sure somebody didn't fall down over there. So it's blood for very anemic patients, and the doctor can decide that cutoff. I think they say 7. They're really quite anemic. I can't remember. Or dobutamine to increase the contractility. And then what you can do is draw another blood gas off of there after a little while to see if it is improved to over 70%. And that's it. Once you've done that, you've completed your 6-hour goals. You've done it all. You've completed the sepsis bundle. Okay? Any questions about anything on this slide? Okay.
Yes, Kyle.
Yes, Heather.
How do I get my doctors to order my venous O2?
Well, they should know about it. It was just in April we had the consultant come and talk about this technique, so hopefully they all remember it. In any case, it is very easy to do, and it is when they give up on the patient in 3 days and send them to the medical center, then they do it then. So but not every patient is severely septic and needs to get to this point. Okay, so. Like Andy said, what this central line stuff is a bummer. Maybe it's not always necessary. Central lines are not good for the patient overall. It introduces infection, it's complicated, it's painful, it's expensive, etc., etc. So isn't there a way around it sometimes? I would say yes. This more recent trial from JAMA in 2010, what it did is it looked at patients who were a little less sick in general than the Manny Rivers people from 15 years ago. And what it did is instead of looking at that central venous oxygen saturation, which is what you would need a central line for, instead they just checked to see if the lactate was going down. They just remeasured the lactate after a certain point. And as long as it was going down, that was as good as double checking the central venous oxygen saturation. So this could make things much easier for everybody. This is a good technique if the patient doesn't need a central line for some other reason, right? And what they did is they just remeasured the lactate. They got the initial value. It was over 4, and so they remeasured it after 2 to 6 hours. And as long as it was going down by at least 10%, that was as good as anything. Okay? So they have this calculation here that they do, the initial minus the result, divided by the original times 100. I mean, what I would just do is take your new lactate, divide it by the old lactate, and if it is less than 0.9, then you've done it, right? Then it worked. Does that make sense? Mm-hmm. Okay. So this could be a good deal. So when to remeasure it exactly, I would say after you've done something. So after you've completed your fluid boluses and their blood pressure is looking good, that would be the time to remeasure the lactate. But to complete it by 6 hours would be good. Okay. And what about those patients where the lactate isn't over 4? What if it's 2.9 or 3.5? Again, remeasuring the lactate. Logical and easy and non-invasive, relatively non-invasive thing to do to just ensure things are going in the right direction. Okay? Because not every patient presents at the peak of their illness to the emergency department. Sometimes they get sicker on med-surg. And so to have that repeat lactate just makes sense. Okay? The other thing about lactate, there's this taboo about it where you couldn't use a tourniquet at all to get the lactate. And so we looked it up. That's like an old wives' tale, and it's not true. And so we told the phlebotomist, or we are asking Char to tell the phlebotomist, you can use a lactate for a minute, or you can use a tourniquet for a minute is fine, okay? It's not going to ruin everything. The worry is that you get this anoxic blood under the tourniquet, and then your lactate would be artificially high because of the tourniquet. but it's not a big deal to have it on a minute. Or else you can have the tourniquet on, get the needle in, and then throw away a little blood and take the lactate out, after the tourniquet's been off. So we're relaxing the lactate tourniquet rules to make this easy.
Gray tubes in our drawers.
Yep. You know how many gray
They have to
tubes?
be refrigerated though too, right?
Yeah.
Right. As long, I mean,
Cup of ice.
But basically,
Oh, gotcha.
lab's gonna come and draw that second blood culture,
Well-
and they'll get their lactate done.
But we can
Not
draw it
always.
with the first, with
Yeah.
our IV
And then
start.
you have it
though.
right
Good.
away.
I guess you
And then get
could.
it going faster.
Yeah, that'd be cool.
Because especially these patients usually have
'Cause
poor
why not?
IV access.
Yeah.
So
Yes.
we tend to not want the phlebotomist, using the vein that we could possibly use.
Okay.
We just
You know,
need
the things
gray
that-
tubes.
Yeah, we
Yeah.
need that line.
You want gray tubes? You know how many gray tubes?
We do have, don't we have some in the drawer? No, we do.
Someone handed
We
me a
used
really
to.
cool gray thing. Was that you the last time I was
Yeah,
down
that
there?
Refrigerated.
I
It
don't
was
know.
like this cold.
That
Yeah.
comes from the lab, but
Yeah.
we can just use a cup of ice too.
Mm-hmm. Okay, and as long as the thing goes straight into the machine, I mean, it's not really going to be much chance for it to get hot either. But yes, try to be conscientious and follow the rules about lactate as best you can, although we are relaxing them just a bit. Okay? So again, just to review our goals, okay, not every patient needs a central line, as Andy said. But, I mean, ideally, we wish to get the antibiotics in within 1 hour, if not 3, to complete our fluid bolus within 3 hours, and complete your hemodynamic goals within 6 hours, whether that's all your central line stuff, or whether you're just doing the lactate remeasuring game, okay? Other bonus tidbits about sepsis, remember to give a good handoff to the next nurse, whether it's going to be somebody in the ICU over the hill or somebody in the ICU upstairs. All this stuff is common knowledge. All this goal-directed hemodynamic endpoints are well known and well recognized. You can communicate how well you're reaching the goals and what you still need to do, et cetera, okay? Source control. If the patient has something that can be cut off and they're this sick, then it ought to be done that day and not tomorrow, okay? So somebody with a diabetic foot and severe sepsis ought to have it cut off tonight and not tomorrow because they could die tonight.
In the ER?
No, yeah, thanks, Heather. Thanks, Heather. No, you can go to the operating room. You got a few minutes. Thanks, but yeah, source control is really important. We'd say 12 hours for source control, hopefully, okay? If that's possible. Up in the ICU, they're going to be doing all this infection control stuff, which is important, all the basic housekeeping stuff. Glucose control, modest glucose control within 140 to 180. Again, this is kind of more upstairs type of stuff. The ventilator settings, you want to make sure the respiratory therapist has got the right amount of PEEP for the FiO2. That's kind of their business to make sure that that all is being done well. So they got a lung protective ventilation strategy. And that's it. Now I want to give you guys a little bonus thing about sedation because I wanted to talk about this a little bit. Okay, so if you have to intubate these patients, the doctor's probably going to be wanting a cardio-stable drug like etomidate or ketamine is a good one. Ketamine, I guess, the one drug you're not supposed to give in the emergency department, but you can give it if you're RSIing them, I guess. So you give a touch of Versed to make sure they don't have any bad dreams. So you do that, and so then post-intubation, what I'm suggesting you guys do in the emergency department to avoid the use of inconvenient drips, especially if you're going to be shipping the patient by ambulance, is to try for IV push, analgesia first, and sedation, okay? So the most stable drug that's least likely to drop your blood pressure is supposedly the fentanyl. So I think you should be getting this on board, whether the patient expresses pain or not, giving it in little 25, or if they're really looking like they're struggling, up to 100 microgram doses push. And the point is that not only is this taking care of the painful endotracheal tube, but it's taking care of the air hunger that their brain is causing them to freak out about. The opiate directly addresses the air hunger. And so getting that on board. And then for the sedative, I mean, propofol is cool. It's pre-mixed. That's a good drug. Real titratable. But otherwise, IV push Ativan lasts for a long time. And so I think that this is also a fine option, especially if you're going to be shipping the patient someplace and they don't want to be dealing with 4 drips. You'd rather deal with 2 drips on the ambulance than 4 or 5. You can really wean it down by choosing Ativan as your sedative. Okay, so again, make sure you're giving something for pain. But also, get the sedation going. And then, the thing, I really don't like is when we say, well, the best sedative is the vecuronium. That's the one that really tranquilizes the patient and makes them feel real good. And no, I mean, it just makes you feel good because they're paralyzed and they cannot express their agony in this state. So paralyzing the patient is something you have to do sometimes. But the bleeding hearts among us, hope that you don't have to. I don't know about ambulance transport. I mean, that's a really rough, bumpy ride.
I like them paralyzed.
Yeah, but I mean, I wonder if one day we can figure out how to optimize our sedation and pain control to an extent where you don't have to do it.
Every time they're not, I always feel like
I know.
Double up. We're like, they're already bucking the tube before I get them in the ambulance, and now we're going to go down and...
Yep. So they should have more. If you're having to paralyze, that means you're behind on your fentanyl and Ativan. So you got to be, doing that more. So anyway, I'm not trying to tell you guys. I mean, nobody quite knows, okay, what the ambulance is like. But yes, the bleeding hearts among us want you to do this. And upstairs, this is an ICU thing, but upstairs, up in the emergency department, the ambulance, absolutely snow the patient to deep sedation, make them unarousable. I don't care. But upstairs, they're going to need to be getting them to a lighter level of sedation so they can be extubated real easy. Okay, this is upstairs stuff. Again, I'm not going to ask you to remember all this stuff. We're going to be printing out, okay, this is going to be our medical staff approved triage protocol, sepsis guideline. We're going to be taping to your computers downstairs so it's easy to see, remember what the SIRS vital signs are, remember what all your goal things are, et cetera, et cetera. So it should be easy to see. And this is it, man. Sepsis is not a high-tech, it doesn't require a lot of high-tech stuff. It's not all that difficult. It just requires a bit of urgency, a bit of recognition, and I think we can do it. That's that. So yeah, time for questions.
You said our rate was high on our mortality?
Yeah, so I don't know how this quite works, but yeah, they measure something called, basically they abstract somehow the patients with a discharge diagnosis of sepsis, and the proportion of those patients who end up dying, it's been too high. So whether that is a paperwork problem or some kind of coding problem, or if we're just not consistently doing the standard stuff, let's just make sure we're doing the standard stuff.
So no number, no value.
Oh, I couldn't tell you. I can't remember what it
I
is.
thought we were pretty much doing the standard stuff, don't we? Haven't we been doing it?
Well, I don't know.
Maybe the lactate is...
Yeah, the lactate. So we could be recognizing more patients with severe sepsis, maybe. The point is, too, I mean, here's this thing. Like, okay, we're going to just ship this patient over the hill immediately, right? Because we think they're that sick, or maybe their oncologist lives over there, and so they'd like to be in the valley, right? Well, that's the question. I mean, if you're shipping them over there and letting somebody else do all this hemodynamic stuff and finish that up, is it getting done within 6 hours? I mean, is it? I don't know. So that's what we intend to find out, too, over the next year. Now that we're rolling this out, we can start today, okay? We're going to be, I'm really interested in calling up and following these patients that get transferred to see, is transferring them really getting all the goals met within 6 hours. Because remember, meeting the goals later hasn't worked. There was a bunch of studies about that before this Manny Rivers thing where it just wasn't, they were doing all the same stuff, but later, and it was not reducing mortality.
This is one of those things where emergency department recognition and management can be true key to decreasing mortality and morbidity. And so it's just been something that's, more on the radar scope, I think, in the last year in the literature, and certainly as a corporate initiative. And we're trying to get everybody just thinking about it and moving more quickly.
Yep. So this is it. We're going to see if it makes a difference or not. And obviously, yes, there are patients whose disease is such that nothing will save them. I mean, we're reviewing the cases from last year. I mean, the hermit male found down for 4 days with rhabdo and a big NSTEMI and severe sepsis. What, I'm not expecting you to save this patient. Although that brings up the other point, which is throughout all this, there needs to be a decision about the palliative path in comfort care. And that is also a common thing to find, that, once the family comes around, they say, let's not try, he won't want everything. And so that is a common thing to see too, and we want to definitely respect that and have some less aggressive palliative options available for the patients whose goal is not necessarily survival when it comes to a situation that is quite clearly the end. But until you know that, here are the tools and the guidelines, and this is the gold standard of what to do.
But just like we've, really gotten on the ball with the cardiac patients, the stroke patients, this is just the next, special interest group to come into favor. And you can make such a difference if we just get those, keep the blood work moving, get those cultures so we can get antibiotics in and get them their fluids. None of it's real challenging stuff. It's just get thinking about it.
Just keep your antenna up for that
Right.
patient.